I'm Kate Ringwood. I'm a licensed therapist. I'm licensed in New Jersey, PA, Maryland, and Florida. I own Serendipity Counseling Services, and I specialize in eating disorders. Kate, you want to introduce yourself?
Yeah, it's super simple. I'm also Kate. I'm Kate Regan.
Mhm.
I am a dietitian and owner of Wholesome Nutrition. We're a virtual group private practice who also specializes in eating disorders, but also people who are just struggling with like their relationship with food, don't necessarily have a diagnosis, which like Kate also does. But we'll talk about diagnoses and all of that soon to come. So yeah, nice to see you all and meet you all. I'm excited.
Um, all right. So first things I'm gonna just start with just a kind of a brief overview of the different diagnoses. I'm sure that many of you are kind of familiar with these, so I'm just kind of I'll skim through them. If you have any questions, feel free just to kind of pause and stop me, and I'll try to answer them. So the first one that we have here is anorexia nervosa. This is mainly just restriction, immense fear of gaining weight. Um, they tend to be underweight when diagnosed with anorexia, but they do not have to be. There's again that disturbance of their body shape or size, and the main behavior is restriction here. So some warning signs are going to be weight loss, body dysmorphia, kind of seeing yourself a different way than you actually may appear, high levels of anxiety and depression, low self-esteem. There may be some cold tolerance, fatigue, dizziness, the difficulties with sleeping, and just some interesting facts about anorexia is it's actually one of the highest overall mortality rates among all psychiatric disorders, with the highest actual suicide rate. And the mortality rate is 12 times higher than the general public. And about 25% of those that have anorexia are males, and they're actually at a higher risk of death due to the delayed diagnosis and the stigma that men don't have eating disorders. The next one's bulimia nervosa. This is that restriction piece is sometimes seen with it because it's binge purging. So the binge is diagnosed as having a larger than typical amount of food in a small period of time with a lack of control around that. And then there's some compensatory behavior. So that may be restriction, purging, laxative use, diet pills, exercise. And there is going to also be that extreme dissatisfaction with their body as well. Some warning signs here, obviously that binge purging. You may see someone go to the bathroom right after meals. You may notice a lack of control around food, weight fluctuations. Sometimes self-injury is seen with this. There may be sore throat, calluses on the hands and the knuckles, heartburn, acid reflux. And about 5% of American women struggle with bulimia in their lifetime. And 25% of those are males that will struggle. And I'm going to get more into co-occurring disorders a little bit later, but about half of those that struggle with bulimia actually have some comorbid anxiety disorder. All right, binge eating disorder. So this is going to be that binge episode that we talked about with eating a larger than typical amount of food in a small period of time with a lack of control, but without that compensatory behavior. So again, there is going to be often distress around one's body as well. So similar warning signs to bulimia, where you're going to see maybe a lack of control around food. You may see weight fluctuations. There tends to be a lot of shame, guilt, and embarrassment around the binge episodes. So that's typically pretty high in these clients. You may see hiding food, eating food in secret, or eating alone, low self esteem. Um, about 30 to 40% of those seeking weight loss have binge eating disorder. It's actually the most common, as you can see by this chart. It's way more common than any other eating disorder. Um, it's 3 times more common than anorexia and bulimia. And despite the stigma, often people think, oh, binge eating disorder, someone is in a larger body. Only about 70% of those diagnosed with binge eating disorder are actually considered quote unquote obese. Oh, and I really think that this is pretty fascinating. Binge eating disorder is more common than breast cancer. So then we have OSFED, or other specified feeding and eating disorders. So this is the second most common, as you can see by this chart, and more common than anorexia and bulimia. And that is because it is kind of the overarching diagnoses if someone does not fit completely in the criteria of the other eating disorders. So what that means is, for example, with anorexia, if someone's not considered underweight, that would be considered OSFED. As far as bulimia and binge eating disorder, it is typically a lower frequency than the actual diagnosis requires, and that would be considered OSFED. The other ones are purging disorder, which there's no restriction, no binging, just purging, or night eating syndrome, where someone will wake up in the middle of the night and eat. And the last one is ARFID, or avoidant restrictive intake disorder. Now, this one is typically seen, it can be confused with someone being a picky eater. It's seen very commonly in adolescents. The difference here between ARFID and someone being a picky eater is that there's an overall disinterest in eating food, and not enjoying eating. With a picky eater, they might avoid foods because they say they're gross or icky. But this is typically, it can be textural that they're avoiding foods, or it can be foods that they actually enjoy the taste of, but there's a fear behind them. This may be a fear of choking, vomiting, feeling full, having stomach pain. You may see folks avoiding certain events because they're not sure if it would be a safe environment. What if they choked? What if there's not food accessible? And there's often a lot of anxiety around food. With a picky eater, there tends to not be that anxiety or fear of actually eating. Some warning signs: you may see some dramatic weight loss. There's tends to be a cold intolerance also, lack of energy, lethargy. Um, there can be often GI issues, and you may see foods that they used to typically like being restricted more and more, and having a more and more narrow food that they will eat over time. There's no body disturbance in this, though, but there does tend to be a lack of appetite or interest in food. Nearly half of children with ARFID report fearing vomiting or choking. About 1/5 say they avoid certain foods because of sensory issues. ARFID is pretty common with autism, and very common also with anxiety disorders and ADHD. So there was a question here. Said, would someone who only eats raw meat considered ARFID? I do not. Well, I guess I would be more interested in what's behind just eating raw meat. Never necessarily heard of that could be considered as ARFID. It was more so, oh, they feel it's healthier. Okay. So this may be more into maybe an orthorexic kind of tendency, with which orthorexia is not an actual diagnosis, but it's a term we often use within the eating disorder community, and it's a preoccupation with eating quote unquote clean or healthy foods. Um, that may be more in that realm. Okay. So, co-occurring disorders within eating disorders. So, with this study, that was done, about 97% of those that were hospitalized for an eating disorder were found to have some sort of co-occurring condition. 94% had a co-occurring mood disorder, mostly major depression. It's very common. And about 56% were diagnosed with anxiety disorders. 20% had OCD. I often see, if someone's not diagnosed with OCD, I see a lot of OCD-like behaviors within the eating disorder realm. 22% had post-traumatic stress disorder, and 22% had alcohol or some kind of substance use disorder. This kind of emphasizes the importance of, if you see some type of disordered eating or eating disorder among who you're working with, it can be really, really beneficial for them to have a therapist on their team. Okay, so this diagram I think is super cool because it starts at the top. So if you think of a baby that is born, they are born the ultimate intuitive eater. What this means is a baby is able to cry when they are hungry and ask for food, and they are able to push away the bottle as soon as they are full and satisfied. And you see this all the time with babies. They just cry the instant they're hungry and push away the bottle when they're done. And once they get older, they start to be incorporated into our society, and our society is filled with diet culture. We see ads all the time for different diets. We see people posted in media in certain outfits, certain body types. It is everywhere. I'm sure that none of you would argue that. And when we see these things, it actually leads to kids, adults they value that kind of image. Because it is everywhere, the kids will look up to that and they start dieting themselves. So 35% of those who diet actually develop disordered eating. So that's why I kind of did the arrows pointing from, okay, this dieting is going on. 35% of those folks actually have disordered eating. Now, 25% of those that have disordered eating develop an eating disorder. And what we focus on through eating disorder treatment is getting back in touch with that intuitive eater. It is still there, but it is pretty lost. And so we focus very much on getting in touch with those hunger, fullness, and satiety cues that are going to influence those intuitive eating behaviors.
So to piggyback off of that, that's kind of explaining both what the therapist and the dietitian have a role in recovery and helping these clients. So a little bit more about how dietitians have an influence and impact in recovery. And I know there's a couple of RDs here, but this is helpful for dietitians and for all providers to know, so that they know specifically like how the team works, right? Okay, the therapist is going to cover these things, the dietitian is going to cover these things, so I know what my role is then, right? So essentially, first and foremost, we want to make sure we're assessing the client's eating history, right? So what's been going on if you're seeing a teenager, an adult, what has been going on in your relationship with food since you're a child, right? We want to go all the way back. Any significant memories they have around food, any significant memories they have with, people encouraging them to change their body or change the way that they're eating. We also want to know about their family's relationship with food and body, because we know that the family, that nuclear unit, has a huge influence on how children come and grow up to perceive themselves and food. And then we also want to know what's going on with their current relationship with food, right? So is there any restriction going on? Are there any behaviors that are concerning to them? Is there any binging? Is there any, calorie counting or obsession with food in any way? So we really want to get a full assessment about their whole timeline, essentially. And then in combination with the therapist and all other providers on the team, we help to determine the appropriate level of care. So towards the end of this, Kate will kind of go into all of the levels of care for eating disorder treatment. So depending on how the client is presenting, how severe their symptoms are, they might need a different level of support, and that is decided by the whole team. We can make that recommendation together. Next thing here, no surprise, we are creating a meal plan to ensure adequacy for fuel, variety, and preferences, while also considering individual needs. I have heard so many doctors say, thank God you're taking over this part of things for me, because I can't meet with these patients once a week to go in detail about what they should be eating, how much they should be eating, all of these different things. And oftentimes in recovery, there's a lot of resistance to change, right? There's resistance to a meal plan sometimes. So having that therapist to kind of manage the psychological impacts of how this is impacting them is huge too. So additionally, we educate clients on nutrition science and work through distorted beliefs. One of my favorite ones to work through recently is that carbs are going to make me fat. Carbs are going to make me gain weight. We can tell pretty clearly that that's a distorted belief around this type of food, right? Carbs are super demonized in the past decade or so, I would say. So that's a really big one that we see clients presenting with. So as the dietitian, we're able kind of to walk them through all of the nutrition science behind carbohydrates, behind why their body needs these foods, right? To kind of help them progress in their recovery and making peace with all of these foods that they're fearful of. Next up is developing an action plan to include coping skills as it relates to the food behaviors and body image, right? So if we're seeing a client who is really struggling with binging, right? We're coming up with coping skills that can help them reduce their urges to binge. We're coming up with coping skills that can help them regulate their emotions, all of those types of things, again, in collaboration with the therapist. And then obviously we are a treatment team. So the medical doctor, the psychiatrist, the therapist, I am constantly communicating with all of these members of my client's treatment teams so that that client can get the best support, right? So treatment teams are not only helpful, but they're pretty necessary in having a client progress in treatment. So yeah, we can go to the next one. Oh, this is yours.
Okay, so weight shaming. 40 to 60% of girls ages 6 to 12, so we're talking young, are concerned about their weight. 79% of those on a diet report coping with weight stigma by actually eating more food. So these young adolescents are feeling like they're feeling concerned about their weight. They're feeling like they're not satisfied with their body, and they're going on these diets. Yet they are coping with those thoughts by actually eating more food. And this is a great example of why diets do not work. As far as weight-based victimization among youths, they've been linked to actually having less physical activity, lower self-esteem, body dissatisfaction, and lead them to be at a higher risk of an eating disorder. Shaming does not equal motivation. A lot of folks think this is about willpower, and willpower is very shame-based. So we very much a big thing that I work on is reducing that shame among the people that I work with. I have this video to show you guys, and I really, really love it. So I'm just going to bring that up right now.
There's a big problem at the center of our research on weight and health. What's the problem? Well, picture a society made up of dogs. Let's say poodles are the bossiest group. They're the ones you see down at the doggy park barking at all the other dogs about how to live their lives in order to be healthy. But the problem is, poodles think that every other kind of dog is just a really big, a really small, or a really fat poodle, when actually the other dogs aren't even poodles at all. They're terriers, or mastiffs, or greyhounds, or labs. And all of the thousands of different dog breeds have different lifespans and different health risks. Each one has evolved to use food differently for different specialties at surviving. Some for staying warm, some for running fast, and some for being strong. They're meant to be different sizes and weights. So the poodles think the mastiffs should lose weight, but a starving mastiff never becomes a poodle. The poodles don't understand that dogs come in many more sizes than they can imagine in their poodle-centric ways. So this becomes a problem when it comes to poodle science. When the poodles did their weight and health research and made their claim that lighter dogs are healthier and live longer, they weren't comparing thinner poodles and fatter poodles. They were comparing poodles and mastiffs. So the recommendation for mastiffs to lose weight is based on the false assumption that if all dogs reach poodle weight, then all dogs will have poodle health. But once again, a starved mastiff just isn't a poodle. This poodle science doesn't even test whether a starved mastiff lives longer than a mastiff who has enough to eat, because one would have to compare mastiffs who maintain poodle weight to mastiffs that maintain mastiff weight. And it turns out that starving mastiffs regain weight, which after all is a much better thing than starving. But the poodles can only see that regain as a failure of mastiff self-discipline. Look, poodles are great, but poodle-centric health policy is a nightmare. Good science tells us that it's better to recognize and respect the ways we're different, because how we're treated, having good friends, having access to decent food, a place to play, restful sleep, and medical care make a huge difference in our health and longevity. For all of us, whatever our size.
Alrighty. Okay.
I love that video every time I see it. I'm like, oh, this is so cute, but also like they drop a bomb at the end and you're like, this is so true. Anyways, so kind of continuing on with the health at every size. Really, we can't talk about eating disorder recovery and eating disorder treatment without mentioning health at every size. We could have 10 weeks of presentations about health at every size alone, but I'm just going to give a pretty general overview so that you can understand what the general approach is and just like what that means when someone says their health at every size aligned, right? I think that word can be thrown around a lot and people are like, I don't understand that. So we're going to talk about it. So essentially, health at every size is a social justice movement. And there are 5 principles that health at every size includes and promotes. So the first is weight inclusivity, right? Being respectful of everyone, no matter what size body they're in. The second is health enhancement, right? Supporting health policies that improve and equalize access to information and services and personal practices that improve human well-being, right? The third one is eating for well-being. So this means not dieting, but instead promoting flexible and individualized eating, pretty much intuitive eating, right? Listening to those hunger and fullness cues and things along those lines. Respectful care. So really working to end weight discrimination and weight stigma in all areas of healthcare. Because we know, and I'll talk about a couple of statistics, just how harmful weight-based discrimination is to our people. And then life-enhancing movement, supporting people to find a really positive relationship with movement that feels good for them, right? It doesn't have to look a certain way. It doesn't have to be super intense, but just getting people moving their bodies, because we know that that's health promoting no matter what size body you're in. So a little bit more of a description here. I oftentimes hear that people get 2 things confused. health at every size and healthy at every size, right? So when we say health at every size, we're not saying that everyone in every body is healthy, right? There are people along the whole spectrum of body size that can be both healthy and unhealthy, right? People on the lower end, people in the middle end, people on the upper end. What we are saying, though, is that health can be pursued at every size, right? No matter what size body you're in, you always have full capability to work towards improving your health with a behaviors first approach, right? So asking questions about, if a patient's walking into your room, you're asking questions about their lifestyle. What are their behaviors versus, using their body as a business card and just judging them right away and saying, oh, they're in a larger body. They must be pretty unhealthy. They must eat a ton of food. They must not ever exercise. I can't tell you the amount of clients that I've worked with in larger bodies who have perfect lab values, who do really intense exercises, who eat a pretty, well-rounded and varied diet. And they're just in that body, and that's a healthy body for them, right? So we can no longer use bodies as business cards. So really getting into those important questions about lifestyle, do you have enough access to food? What are your eating patterns like? What is your movement like? How do you engage with movement? How's your self-care? How's your mental health, right? How are you taking care of yourself? So really asking those important questions to get more information about their behaviors so that can inform what our recommendations are, right? Versus just telling someone, eat less and move more. We're really understanding how we can give personalized advice for that individual to improve their health, regardless of what size body they come to us in. And again, weight is not a behavior, right? So telling someone that they just need to change their weight, that's not really helpful advice. It's just a piece of data, right? So again, coming back to that behaviors first approach, really helping clients understand how they can improve their health, regardless of weight. Oftentimes, and I understand the limitations here. Sometimes you're pigeonholed into using BMI as a measurement of health for coding purposes, for diagnosis purposes. So I understand, especially if you take insurance or something along those lines, there's a lot of barriers there in helping those patients receive care. So I understand if you have to use that as part of your practice. However, there are some limitations of the BMI. There's a lot of limitations. BMI is not just inaccurate, but it's also extremely harmful, right? It's inaccurate because it was developed not for use for individual health assessment, right? It was used for a population assessment of data. And it was never intended to be used for individual assessment of health. It was also developed by a mathematician and not a physician or someone in healthcare. And the sample pool that they used was white European men. So really, really difficult, what I would say impossible, to extend that to other demographics. So not only inaccurate, but it's also harmful because what it does is it pathologizes body size, right? It diagnoses someone's body size as a disease. So what that does is create a lot of weight stigma, a lot of weight-based discrimination. And this weight discrimination is associated with an almost 60% increased mortality risk, even after correcting for other risk factors. So pathologizing body size, right, using that body as a business card, what that's doing is making our patients and clients have a higher risk for mortality. And I know for a fact we're all in this field because we care about people and we want to help people get healthier. Judging someone based on their body size is just not the way to do that, right? So a gentle suggestion to kind of ease your way into this health at every size work, if you are a physician, if you have, if you're an OBGYN, whatever you might be, if you usually have as part of your protocol to have the patients get weighed every time they come in, what I would start by doing is just asking for consent from those patients to get weighed, letting them know that, hey, it's an option to not get weighed. We can still do a full assessment of your health. I can still support you in improving your health without even knowing what that number on the scale is, right? So that's a suggestion for you to kind of ease into this work. There's a question over here. How can a person assess their level of healthiness within their body? People often like standards to compare against and use BMI or weight, which may be inaccurate, unhealthy. Yeah, absolutely. Great question. So one thing that for people who are data driven, I like to use blood work a lot. I'm like, okay, we can get your blood work tested every 6 months and kind of see how things are there. That's a really good indication of how healthy a person is, right? And also it gives us a good kind of direction to move in if we see like, oh, high cholesterol, okay, we have some recommendations for that. But other things that you can assess for healthfulness are, you know, what are their self-care practices? What's their mental health like? How is their mood? What is the variety of their diet, which obviously a dietitian can help assess. Again, like talking about behaviors, are they moving on a regular basis, and just kind of looking at that. Another question, how do you propose handling the situation where a physician may require a certain BMI before performing a surgery? Even if I don't agree with that, how do I honor that this patient may need the surgery and not be able to seek care from a different surgeon? I just had this same situation come up. It is beyond frustrating, not only as the clinician, but to just sit there with your client in that space and be like, this really sucks, right? Our system really sucks. And we know, you know, this is kind of my favorite metaphor to use. A doctor and a surgeon will do a weight loss surgery on someone with a BMI over 35, but all of a sudden it's unsafe to do surgery when it relates to anything else when their BMI is over 35. Like, how ridiculous is that? It just doesn't make any sense. And in this kind of situation, it's all about body autonomy, right? You present all of your options to the client, and they can choose whether to try to lose weight to get that surgery, or whether to try to find a different surgeon, or, you know, try a different approach to manage whatever they need surgery for. But it really is a difficult situation, and there's never one right answer. And it just sucks, honestly. There's a lot of problems with our system in that situation.
I come across that often, or I have a few times. And in my situation as a therapist, oftentimes it's just, I call it like just sitting in the suck with them. And you can provide options, but sometimes a lot of those options just suck. And just being there to support the client, it's not necessarily something that I myself as their therapist can fix. It's just about supporting them in how hard this really is.
So next piece here that I want to mention are social determinants of health, right? Because following the conversation that your body size doesn't determine how healthy you are, taking it one step further, weight and health are not just influenced by food and exercise, right? We have to consider all of the social determinants of health. And I know this chart is pretty small on your screen, but I can send you a copy if you're interested in having a blown up version. But usually the message in society is that you just need to eat healthier and move more, right? Eat less and move more is all we hear. For management of health, for weight loss, for all of these different things. But we are looking at a huge cobweb of all of the things that can influence a person's health, right? So we're looking at individual behavior here. That orange chunk is 36% of this pie chart, right? All of the different things that can influence a person's health, 36% comes down to individual behavior. I want you to write in the chat how many of these points, you can see all of the bullet points in there, how many of these points you think are related to diet and exercise within this individual behavior web. Any guesses? 1, okay. Anyone else? 5, okay. It is really hard to see, yeah. I'm not asking you to look, yeah, 2, okay, yeah. So it's actually 3, right? So we can see that there's like, I don't know, 30 points here in individual behavior. Those are related to mental health. They're related to, what are some other ones? Sleep hygiene. They're related to gun behavior, sexual activity, all of those different things. And diet and exercise have 3 bullet points in there, right? So the message that you just need to eat less and move more, or you need to fix your diet and exercise more, and everything will be all well and dandy for you is a complete lie, right? And I'm saying that as a dietitian who teaches people how to improve their diet and their health, right? I am acknowledging that it's not as simple as just eating better, right, to improve someone's health. While that's something that can improve their health, it's not as big as I think society would like you to believe. So what I'm saying is here, we have to zoom out, right? Look at the bigger picture. We have to understand that there is a human sitting in front of us, and there's a million other factors that could have placed them in the body that they're in right now, right? It's not just because they have loss of control around food. It's not just because they're lazy or lack willpower, which, is the common messaging we receive about those people. There's a whole story behind that person, right? And we have to look at all of these social determinants of health.
Kate, are you able to just say, since we can't really see it, what the other percents are?
Yeah, sure. So physical environment is 7%. Medical care is 11%. So like access to medical care, quality of medical care. 22% is genetics and biology, and 24% is social circumstances. So some of those things would include like socioeconomic status, education level, where you live in the world, what your air quality is like, all of those types of things.
Awesome. Thanks.
Mm-hmm.
Alrighty. So now it's like, okay, we know all of these things, and what do we do? And especially because the rate of eating disorders in kids under 12 has risen 119% in the last decade. So these things are here. Whether we're talking about it or not, they're here. So the first thing that I always start with is validation and compassion. These are the two biggest factors that can help someone feel supported in whatever journey they are going through. Recovery is not linear. There's going to be a lot of ups and downs and backwards and forwards. Lapses are going to happen. So approaching them with curiosity and asking questions, because they probably don't know the answers. We don't know the answers. And it's just really trying to just learn about the person in front of you and learning what happened so that we can gather more information and see where to go from there. Separating the eating disorder from the healthy version of themselves. So I often look at the eating disorder as kind of, I've called it like a monster before. It's this monster that starts taking over this healthy version of this person in front of you. I talk to a lot of parents who say, I feel like my sweet, kind, joyful child is just not there anymore. I don't know what happened to her. And it's not that that sweet, loving, joyful person is gone forever. They're still underneath there, but they're being taken over by this other thing, this eating disorder. And often the behaviors that parents call out saying, they're irritable all the time, they're angry, they yell at me, that's the eating disorder taking over. Those behaviors are the eating disorder, not that sweet, loving, kind child. So another thing is avoiding using numbers and measurements. So in my work, I very much stay away from counting calories, using any kind of measurements. I often try to promote blind weights so that the client doesn't actually know what their weight is. This can differ from client to client, but I have found blind weights to be the most helpful. And it can take a lot of empowerment to work with a client and make them feel like they deserve to stand up for what they need when they walk into a doctor's office. And this is why I love what Kate suggested about asking consent for someone to be weighed, because if this is something that they haven't seen their weight in a while, weight has it's been shown to have such an influence on someone's shame that they feel about themselves. And how I often have someone come in and be like, oh my gosh, I saw my weight and my day just spiraled. So asking that consent about weighing them can actually influence how the rest of someone's day goes. And avoiding terms like good or bad. I go by the philosophy of all foods fit. And I'm going to get into language a little bit later. But when we demonize foods as good or bad, there's a shame factor attached to that. So oftentimes the connection is, oh, that food is bad. If I ate that food, then I am bad. And I see this very, very commonly among a lot of my clients, and then that shame rolls in. Remember that food does not need to be earned. And having this kind of mentality can be so incredibly helpful when working with folks with eating disorders, that they do not need to exercise X amount of, hours or minutes in order to have breakfast. That their body actually needs food no matter what they're doing. Something I often say to clients is that even the folks who have committed the worst crimes in the world and are are in prison, they still get fed. So every person deserves to be fed no matter what they're doing. Um, focus Focusing on what their body can do for them, not their size or appearance. Um, Focusing on the mind-body connection, such as those hunger, fullness, and satiety cues that I was talking about earlier. And then talk about social media. The messages that we're getting from diet culture, they are there and they are strong and they are powerful. And the more that we talk about them, the more it reduces that shame and kind of putting diet culture on this pedestal that makes folks want to follow it. Really. So you have someone walk in your office and you're not really sure what to do. The first thing is, I think that kind of like Kate was saying, is like any other illness, we need to find out history. And so just something as simple as asking, has anyone in your family suffered from an eating disorder? I don't know how many doctors I have gone to where they have not asked me a single question about whether it's in my family or if I even have struggled with an eating disorder. Those flat out questions can start with giving you a lot of information about that person. Then getting more into detailed questions like, do you have a fear of gaining weight? Do you ever limit yourself from eating certain foods that you really want to eat? Do you eat when you feel, or what you feel like would be a larger amount of food than most others would in a small amount of time? That's a little question around binge eating disorder. Do you feel that food dominates your life? Are you satisfied with your eating patterns? Do you feel out of control around food? Then getting into, are you feeling any guilt or shame or regret after eating? Do you sneak food or feel like you need to eat it alone due to some shame you're feeling? Do you have negative feelings about your body? Does your weight affect the way that you feel about yourself? These are all really great questions to just get the conversation going. So, communication. There's some words that can be a bit harmful and very hard when someone's struggling with an eating disorder. And some of these words can bring on a lot of shame. So that goes back to that good or bad, where if I then eat that bad food, I am bad. So I tend to avoid using words like good, clean, bad, toxic, addictive, dangerous. And then some helpful words can be satisfying, delicious, appetizing, nurturing, or nourishing, filling, crunchy, crispy. This can be used, like an example would be if someone wants to go and eat a certain food. Instead of saying, do you really want to eat that bad food? You may want to ask a question like, is that food appetizing? Is it going to nourish you and fill you up? And that allows that specific person to answer that question according to their own needs. So when you're assessing for first steps and when you first see someone, it's important to take into consideration these three big factors. So the first being medical stability. That's kind of what Kate was talking about with weight history based on, we want to look at trends. So you're not saying what was your weight or have you lost weight. It's more about looking at, with a lot of adolescents or young adults, we take into consideration their entire timeline or lifetime of what their percent weight was. So meaning what percentile they were throughout their life. If they were at the 80th percentile for most of their childhood and all of a sudden they dropped off to 60th percentile, that's a trend that we want to take note of. And looking at any kind of medical complications and symptoms that may be coming up. The next is psychological stability. So what co-occurring disorders do they have? Is there suicidality? Is there substance abuse? And then motivation. So the ability to manage and interrupt behaviors when they are at home. These together are going to really help assess for what level of care and support they need.
So I'll try to go through this pretty quickly, but physical health implications of eating disorders kind of coming off of the physical assessment that Kate was talking about. This is a little bit more specifically what you should be looking out for. Again, because we know that eating disorders have the highest mortality rate of any psychiatric illness, right? So we need to take these things seriously. First of all, cardiovascular complications. When the body is not getting enough energy, this is mostly in like restrictive eating disorders. When the body's not getting enough energy, it's going to start to use your body for fuel, right? So it starts to break down specifically muscle, and the heart is a muscle. So if the heart muscle is disintegrating almost, there's going to be low heart rate, there's going to be low blood pressure, even an irregular heartbeat, which we could also see with purging, and then eventually heart failure if it gets too bad. Neurological complications, the brain consumes about 1/5 of the body's calories, surprisingly, even though it's like 3 pounds. So if, again, the brain is malnourished, there's going to be tingling and numbness. There's going to be food obsession. That person is probably not going to be able to think about anything else other than food. So school and work performance might be dropping off. There's going to be sleep disturbances if that person is going to bed extremely hungry or extremely full from either restriction or binging. Fainting and dizziness is also a possibility. So asking these more specific questions, right? Have you fainted recently? Have you had trouble sleeping? This can give us some insight into what the symptoms are that they're experiencing. GI distress, up to 98% of people with eating disorders have some kind of GI distress, whether it's bloating or constipation or nausea. And then there's plenty of ways that we can manage that through the recovery process. The endocrine system, fat is needed to produce hormones. So if the body is not getting enough fat and or calories in general, there's a decrease in the production of sex and thyroid hormones. There's menstruation disturbance, either irregular menstruation or hypothalamic amenorrhea, which is a complete loss of menstruation. There can be bone loss, and then risk of insulin resistance as well. And then some other things that I mentioned here. If you want to learn more about this, I highly recommend the book Sick Enough by Jennifer Gabbiani. It's really great.
All right, so levels of care. So the first level is obviously outpatient. That's where typically you would be seeing Kate or I about once a week. And then there's intensive outpatient, which is about 3 to 5 days a week, 3 hours each. You're going to typically have dinner and group session. You still will have a therapist and a dietitian just as weekly check-ins, but medical monitoring is not there. So someone's going to be pretty medically stable. The next one is partial hospitalization. This is 5 to 7 days a week and pretty much all day. So they're going to have most meals and snacks during the partial hospitalization program. There's going to be that meal support, groups, therapy sessions, dietitians, psychiatrists, and some medical monitoring, but not any immediate risk that needs to be monitored. With residential, this is 24-hour care for about 4 to 8 weeks. The person's going to be pretty medically stable and pretty psychiatrically stable. However, still there is going to be a decent amount of monitoring, and there's going to be a nurse that they can have on call 24 hours a day. They do see a therapist, dietitian, psychiatrist, doctor, all throughout the week. The next is inpatient. This is about 2 to 4 weeks. Someone's going to be unstable with unstable vital signs. The labs may be somewhat at risk. There's going to be possibly some coexisting medical problems. Suicidality may be a factor, and this is a primary focus on weight stabilization and immediate risk. And then there's acute. Acute is, think like ICU, but for eating disorders. This is going to be the most extreme and medically complicated eating disorders. Alrighty. So, are there any questions that we were not able to answer throughout? Let's see. What would be different in treatment approach, if anything, when working with someone after their bariatric surgery? Therapist perspective. So this is tough. When someone chooses to go through bariatric surgery, it can be pretty traumatic. And there's going to be a lot of weight discrimination there. There's going to be a lot of trauma-based things that you're going to be dealing with. And just working on that low self-esteem that can be a factor. They're all things that typically you may see in someone who is struggling with low self-esteem, body dysmorphia. But really what would be different about the approach, I would say, would be bringing in the factor of shame around weight, how it limits them, the things that they haven't been able to do throughout their life because of their weight. This is a lot of kind of sitting in the suck, what I was talking about earlier, and just working on reducing that shame around it. When someone goes through bariatric surgery, depending on if they just got it or if they had it, a while ago, from what I have seen, it hasn't been super helpful as far as fixing their relationship with food. And so I've still had to really work with clients on that relationship with their body and with food. That part doesn't necessarily change just because they had bariatric surgery. I hope that answered the question.
Yes, thank you very much.
Mm-hmm. Yeah. Any other questions? I put up on the screen just Kate and I's contact information if you're looking for services. I am in Maryland, New Jersey, PA, and Florida. And Kate, which states are you in?
The ones that would be relevant is probably like PA, New Jersey, Virginia, New York.
Okay.
Yeah, depending on where people are. Yeah.
Yeah.
You're welcome.
Awesome. Yeah. And if you guys have any other questions that you have afterwards, feel free to contact Kate or I through email. Happy to answer anything or help out with any, even just referrals if needed.
Thank you, everyone.
Thanks for coming.